Good morning to all. I am Dr. Subbaiah, pediatrician. Today I am going to discuss about TOEING. What a pediatrician must know about TOEING. So TOEING is one of the most common musculoskeletal variations encountered by pediatrician, and it is a frequent reason for referral to a pediatric orthopedic surgeon. So it is a rotational variation of the lower extremity where the feet or toes point toward the midline during gait. So what is normal physiologic alignment of the lower limbs? So rotational alignment of the lower limbs is determined by the alignment of the foot, the rotation of the tibia in relation to the transcondylar axis of the femur. It is known as tibial torsion. So transcondylar axis means the axis formed between the medial and lateral condyles of the lower end of the femur. And the rotation of the neck of the femur in relation to the transcondylar axis of the femur, it is known as femoral anteversion. The intrauterine positioning has an important influence on the rotational alignment of the legs. At the 7th week of gestation, the lower limb rotates medially, followed by lateral rotation of the thighs. So for the remainder of the gestation, the lower limb are medially rotated and the hips and femora are laterally rotated. What are the common causes of TOEING? TOEING could originate from the foot, lower leg and hip. Metatarsus adductus is the common cause of TOEING that originate from the foot, and internal tibial torsion is the cause of TOEING that originate from lower legs, and increased femoral anteversion is the cause of TOEING that originate from the hip. Metatarsus adductus. It is the most common congenital foot deformation and the most common cause of TOEING in infants younger than 1 year. And metatarsus adductus is characterized by angulation at the midfoot with the metatarsals pointing toward the midline relative to the hindfoot. And bilateral metatarsus adductus, here the dorsal view shows medial deviation of all metatarsals and the plantar view shows the bean-shaped or C-shaped foot. So we should assess the flexibility and severity of the metatarsus adductus. Flexibility is determined by whether adduction can be corrected with manipulation back to the normal position. Here it is said to be flexible if the forefoot can be passively abducted past the midline, and it is semi-flexible if the forefoot can be passively abducted up to the midline but not past it, and it is said to be rigid if the forefoot cannot be passively abducted to the midline position. And the severity of the metatarsus adductus is determined by the position of the heel bisector line. So it is a line that bisects the heel pad and is extended through the toes. The normal heel bisector line crosses the second toe or second toe web space. So more severe the deformation, the more lateral the toes that the heel bisector line crosses. And most cases of metatarsus adductus are mild and flexible and they resolve spontaneously by 1 year of age. And second is the internal tibial torsion. It is the most common cause of TOEING in children between 1 and 3 years of age, and it is typically noticed when the children begin to walk. So common clinical features are when standing or walking, the foot points inward and the patella points straight. The medial malleolus is posterior to the lateral malleolus when the child was seated with the thigh directly in front of the hip joint. And in the prone position, the thigh-foot angle is internal. So what is thigh-foot angle? So it is the angular difference between the axis of the foot and the thigh when the patient is in a prone position with the knees flexed to 90 degrees and the foot and ankle are in neutral position. The thigh-foot angle is external when the foot points away from the midline, and it is internal when the foot points toward the midline. An internal tibial rotation typically resolves by 5 years of age. As the child grows, the tibia spontaneously rotates laterally. The third common cause is the increased femoral anteversion. It is the most common cause of in-toeing in children older than 3 years of age. So what is femoral anteversion? So it is the angle formed by the axis of the femoral neck and the transcondylar axis of the femur. So femur with normal anteversion, the plane of the proximal femur is about 10 to 15 degrees anterior to the plane of the femoral condyles of the distal femur. So in this picture you can see the plane of the proximal femur axis. It is formed by the head of the femur, neck of the femur and the greater trochanter is 15 degrees anterior to the plane of the femoral condyles of the distal femur. In this picture, the femur is with excessive femoral rotation is seen. Here the plane of the proximal femur is about 60 degrees from the plane of the femoral condyles of the distal femur. And as the femoral head rotates anteriorly, the greater trochanter rotates posteriorly. So how to diagnose femoral anteversion? By doing hip rotation. Hip rotation is measured with the knees flexed in a prone position. So internal rotation is measured by rotating the leg away from the axis of the body. By doing this, the hip rotation is measured internally. And the normal range of internal rotation, the average amount of internal hip rotation during childhood ranges between 40 and 50 degrees. And the patients with increased femoral anteversion may have as much as 90 degrees of internal rotation. That way it allows the legs to rotate flat against the examination table. And children with increased femoral anteversion may prefer to sit in the W position. And external rotation is measured by rotating the leg towards the axis of the body. Here the hip is rotated externally. And again the normal range for external rotation in childhood ranges between 40 and 70 degrees. Differential diagnosis, you should rule out the other causes of in-toeing. It could be due to cerebral palsy, developmental dysplasia of the hip, clubfoot. And these conditions usually can be excluded through history and clinical examination. Management. The first step in the management of in-toeing is establishing a correct diagnosis. And the most important aspect of management of rotational causes of in-toeing is parental reassurance, because most deformities correct spontaneously and that even in persistent cases adverse long-term sequelae are rare. The traditional treatments such as the infamous boots and bars and orthopedic shoes do nothing to change the natural history of these problems. And management of metatarsus adductus. If the metatarsus adductus is flexible, usually it resolves spontaneously, and treatment including any stretching exercises are not recommended. And if it is semi-flexible, observation is recommended for the first 6 months. However, if the family prefers more active therapy, passive stretching can be done. So stretching consists of laterally directed pressure on the head of the first metatarsal to correct the malalignment. The position should be held for 10 seconds and it should be performed 5 times per foot whenever the infant's diaper is changed. And if the semi-flexible metatarsus adductors persist after 6 months of age, or rigid metatarsus adductors at any age should be referred to pediatric orthopedic surgeon. Corrective casting may be necessary. And management of internal tibial torsion. For children with internal tibial torsion who are less than 8 years of age, management consists of observation and parental reassurance. The natural history is one of spontaneous resolution. Management of increased femoral anteversion. For children with increased femoral anteversion who are less than 11 years of age, management consists of observation and parental reassurance. Again, the natural history is one of spontaneous resolution. What are the indications for referral? When semi-flexible metatarsus adductus persist after the age of 6 months, or rigid metatarsus adductus at any age, unilateral or asymmetric in TOEING with findings suggestive of cerebral palsy or developmental dysplasia or dislocation of the hip. Cosmetically or functionally unacceptable in TOEING due to internal tibial torsion in a child older than 8 years. Cosmetically or functionally unacceptable in TOEING due to femoral anteversion in a child older than 11 years of age, and in TOEING that does not follow the expected clinical course. Thank you.